Welcome to Workplace Whispers with Dr. Olufemi Ogunlowo, where we tackle the most pressing issues in work, business, and human capital. Now, Dr. Ogunlowo is a seasoned HR expert and CEO of Strategic Outsourcing Limited. He has spent decades navigating workforce management. Now, on this episode, we would discuss a very crucial topic that directly impacts millions of Nigerians: the enrollment of employees in health insurance programs. Now, with the Nigerian government's recent mandate making health insurance compulsory for all citizens and legal residents, understanding the structure, the benefits and challenges of the system has never been more important. Well, to help us break it down, we are joined by a distinguished expert in healthcare management, Otumba Lekon Iwinla, the MD CEO of Ultimate Health Management Services. My name is Praise Mba. Welcome to Workplace Whispers.
Thank you. And thank you, Otumba, for joining us on Workplace Whispers. It's a pleasure to have you.
The pleasure's mine to be here.
Thank you, Otumba. And I think we're just going to dive in straight away. My first question to you is this: is healthcare a right or a privilege?
It's a right.
How is it?
Let me say this clearly. At the beginning, it was considered to be a service that must not, in fact, should not even be paid for at the beginning. But as things unfold, it has now a metamorphosed from a free service to a multi-trillion-dollar or naira business. And now healthcare is a huge business. And that is the more reason why when the law was first passed in Nigeria, it was considered to be, the law focused strictly on the formal sector. And why that was done, I will explain. It is the statutory responsibility of every employer of labor to provide for the medical needs of their workforce. That at the beginning translated to certain percentage of the basic salary of the entire workforce to be paid as medical allowance.
Okay, so I'll let you continue. So we're going to make two distinctions. One is people in employment, which is of course our focus because this is Workplace Whispers. And second, the people who are not in employment. Because the law says, according to what Praise just said to us, everybody resident in Nigeria. If we want to take all of that into these whispers, it will be almost impossible. So we will limit for today our conversation on employees, and we'll invite you back so that we can then talk about other Nigerians. All right, so
let me also touch on briefly the class or the category of Nigerians that are seen to be vulnerable. The law also identified the fact that there are 83 million Nigerians that are vulnerable. And for about a couple of years now, the federal government has been earmarking about 2% of their consolidated revenue to provide defined healthcare services for those that are seen to be vulnerable.
Well, people will say they can't feel it.
The issue is this: it's a new concept that was deployed by the federal government, looking at healthcare and plugging healthcare in the same sockets. Looking at demand and supply, I'm now plugging it in the same sockets. Because before now, government has been looking at healthcare from supply chain or supply side, in the sense that government on a yearly basis provide budgets to refurbish government hospitals, starting from primary healthcare centers to tertiary level. And at the end of the day, they equally deploy doctors, nurses to work in those facilities, especially at the grassroots level, where poverty is visible. People can't access care in those refurbished primary healthcare centers. That led to those primary healthcare centers always going moribund shortly after they are refurbished. Now, it was when this government really discovered that it was meant to be supply being plugged in the same socket with demand. That now led to the deployment of the consolidated revenue into two subheads. 50% of that fund goes to National Primary Healthcare Agency to be deployed to individual states or the Federation, 36 and FCT, for the refurbishment of the primary healthcare centers at the grassroots level in phases. 45% of that fund also was deployed or is deployed to National Health Insurance Authority For any state that has applied or has assessed the fund in National Primary Healthcare Agency, they must also go to NHIA to collect certain percentage, a fraction of what is due to them, to implement the vulnerable health insurance program. It's called Basic Healthcare Provision Fund.
Otumba, we will keep the vulnerable in a different box today. We'll come back to it. Most of our listeners are engaged in employment, so we would focus on what will benefit them directly, and then we'll talk to a wider audience talking about the vulnerable. Now, we have thousands of staff out there, and they always come back and they say when they go to the hospital, when they try to access healthcare, they only get paracetamol. And yet we say that under the Act, the National Health Authority now, not the insurance as it used to be, Act, that 5% and 10%, etc., that is contributed. But when people access healthcare, they simply get paracetamol.
Let me explain that quickly. What the federal government did in 2005, when the Social Health Insurance Program was activated for the federal civil servants, it was a systematic implementation of health insurance in this country, because by law, it is the statutory responsibility of every employer of labor to provide for the medical needs of their workforce by paying certain percentage of the basic salary as medical allowance. And if you look at the first law that was passed, which is the Act 35 of 1999, that law focused strictly on the formal sector. Why that was done was quite intentional, because that was designed to encourage every employer of labor that is meant to be paying medical allowance to now convert their medical allowance to health insurance premium for their workforce, because it has been confirmed globally that when medical allowance is paid to staff, they never utilize it to procure healthcare services, and they eventually resort to self-medication or even resort to seeking spiritual intervention, going to sleep in the church or mosque, believing that prayer will heal them. And we all know that whatever the sickness is, as little as headache, if you don't take the right medication to cure it or to deal with it, it will never go.
All right, so Otumba, are you saying now, and we can speak to all the HR practitioners out there, that it is actually not the goodness of the company, it is actually a requirement of the law that every employer of labor must and should provide for the healthcare of their staff? Is that what you're saying?
Precisely. As a matter of fact, let me go a step backward a little. First of all, I want to commend you for creating this platform for us to discuss this, because if there is anything that has been deeply concerned, is the fact that there's a need for employers of labor to understand the fact that there are some basic requirements they are meant to comply with as an employer of labor. Provision for medical allowance and for conversion of medical allowance to health insurance premium is one on that platform.
So it is not discretionary.
It is not discretionary. And most of the time when we meet with our employers of labor, the first thing we put on the table is the fact that whatever you are doing is statutory, so it's not discretionary. The minimum is 10%, and what the federal government did when this program started was to have instructed the head of service at the federal level to come up with the nominal rule of all the ministries, departments, and agencies, which was thereafter transferred to the Office of the Nigerian Federation to pull out 10% of everyone from the lowest to the highest.
Yeah, but that's
government. I'm just saying this. Okay. That is government. For the private sector, it was meant to be a minimum because the salary structure differs. In the private sector, we all know that the private sector pays better than government most of the time. Now, private organizations are meant to pay beyond 10%, depending on their salary structure. And that was why the former law, the first law, focused strictly on the formal sector. Formal sector is organized private sector and the public sector across the national and subnational levels. Yes. So that is exactly what the law says.
Okay, but let me take you back just a moment. Yeah. The law says 5% and 10%, but it denominates it on the basic and not on the gross.
Let me clarify that as well, because I know that this particular issue you brought up now, over the years has actually generated a lot of conflict and confusion, I would say. Because you see, when the issue of 10% and 5% came up, some of our people that seem not to have gone deeper to understand the rationale behind the 10% and 5% just took it hook, line, and sinker and deployed to the organized private sector. It was not meant to be. When the public sector scheme was designed and developed, actuarials saw it to be 10% that would be contributed by the federal government being benchmarked with the benefit package was seen not to be adequate. And that was what led to, okay, what would you think would be adequate as the right percentage of deductions that will cover the primary services, which is known to be the cornerstone of healthcare service across the globe, then the secondary and tertiary services, and it was confirmed to be 15%. At that point, government muted the idea of asking the individual public servants to now begin to contribute their 5%. But the fact that the salary was seen to be low then, and Oshiomhole then was the NLC president, they said no. Government now said, okay, we won't kill this novel idea because of the 5% contribution. We would deploy a process whereby this program will start on 10%. But whenever people walked into their facility and they assess care, whatever consumables is given to them, they now pay 10% of that value right on the spot.
Was that the co-payment?
That is a co-payment. Okay. And that arrangement, I want to say it authoritatively on this platform, was meant to last for just 2 years. Thereafter, they now review the workability of what was done for 2 years and thereafter migrate to the deduction of 5% to augment the 10% that was being paid by the federal government. Now, let me break it down further for clarification purpose. If any civil servant should apply for a loan today, either for housing, for bicycle, motorcycle, or car, or vehicle, it is equally a function of a fraction of your basic salary that will be worked out for you. Government or the employer of labor is not bothered about whether you want to buy a Prado Jeep or you want to buy a Lexus Jeep. The money that will be given to you is given to you. It's not left for you to buy your dream car or hire the dream apartment you wanted to hire. The same thing goes for that 5-10% we are talking about. And the same thing quickly is applicable to whatever any employer of labor is equally paying as premium. As a matter of fact, let me quickly clarify this, because I know there are a lot of confusion in the organized private sector concerning the workability or working out of the premium for private companies. First of all, let us note, there are no two companies paying the same salary in this country, except if one is copying the payroll of another. All right? Okay. So what that means is that for the health insurance to work, organizations should just look at how much is being paid as medical allowance. For instance, if this organization is paying, let's say, 10,000 naira per staff at a low level per month for medical allowance, and now you have decided to convert it to health insurance premium for them, that is basically 10,000 multiplied by 12 months, which is 120,000 naira per annum. Should you now want to enroll your staff on the health insurance program, you ask 2-3 HMOs to present their proposals. One thing is equally very clear at this platform, I want to clarify. There are no 2-3 HMOs that are marketing the same products. So first of all, there's the need for the management to look at their staff strengths and say, okay, we are enrolling ABC. How many HMOs do we need? We also need to bear in mind the fact that the HMO business is equally driven by volume, like every other business across the world. So if you have a small staff strength, like about 10, 20, 100, and you are looking at hiring maybe 2-3 HMOs, you already clean the program at the beginning.
Absolutely.
Because the risk management that we're talking about here is equally driven by volume. Those are the challenges that we have faced, we have seen working out. Now, let me just quickly wrap it up before you go to the next question. Now, you have 120,000 per annum for the lowest level of your staff here. If you eventually choose, let's say, 30,000 naira benefit package from the HMO that you have chosen, even if you are going to choose two, you need to first of all harmonize the bouquet of the 3 HMOs or 2. And
standardization.
That is it. Thereafter, you now say, okay, 120,000 is what we have for the junior staff. We've chosen a bouquet of 30,000. What that means, is that the junior staff will be enrolled. If he's married, his spouse will be enrolled. That is 30 multiplied by 2, making 60. If he has 2 children or 3, 4, 5 children, whatever the 120,000 covers is what you are providing.
Okay.
Should that staff now have more than 2 children, it is equally, their staff will now also still refer back to the management. I have 3 or 4 children. Could you please deduct the premium for the extra 2 children from my salary to cover my extra dependents? Unfortunately, when this program started, majority of the people that started this program, including the clients, the employers too, were not adequately educated about how the premium works. So everybody was just looking at family premium. As a matter of fact, we've had situations where organizations with higher number of spinsters and bachelors enrolled everyone on a family plan. That also led to a lot of questions. Because if I am not married, why should I be paying for the child that I have not bear? I don't have. Are you getting me? Some staff felt shortchanged, which led to a lot of infractions being committed along the line. So I want to pause at this point because those are the issues we are going to be addressing as we move on.
But more importantly, because I think the pain point of employees is not so much about the administration, it's so much about the benefit. When they walk into the hospital and they make that complaint, every day our HR team gets complaints about, I just got paracetamol, or I didn't get to see a consultant, or I didn't get to have secondary care. Everything is just typhoid and malaria. Now, how and what can we do to encourage HR practitioners and business owners to actually understand these concepts properly and put in place the benefits that will let their employees have the right access to healthcare?
First of all, is for the employers of labor to understand the fact that insurance premium is not something that people sit somewhere to cook up. It is actually determined. So it's not an amount that we keep negotiating like rice and beans. If there is anything that we've seen playing out so vividly across the health insurance issue, is the fact that every employer of labor, including those that are seen to be knowledgeable and literate, by the time they are looking at the premium, they are not just looking at the fact that the premium was designed or developed actually and was meant to basically take care of the health risk of those that have been brought on the scheme. They keep looking at, can we pay from 30,000? You see somebody asking for 18,000. You can say, pardon me? Are you getting me? That's a major challenge. Number 2, which is...
So what can we do about that?
What we can do about that, it has been addressed by this new law, because this new law has now empowered the regulatory agency that all the health maintenance organizations that are accredited in this country must present their healthcare benefit packages to the regulatory agency for approval and coding.
Okay.
So that goes to say that, yes, I should be on the letterhead of the actuarial that they hired. That goes to confirm the fact that, yes, this product is not cooked up at any particular corner by anyone. Because what we've seen playing out over the years, I'll tell you quickly, is a situation whereby you see HMOB looking at what HMOA is doing and looking at HMOC and D. If you are charging 25,000 and look at what she's doing is 24,500, they just put their own at 23. That is direct marketing of the business. They have never put into consideration the fact that the premium was meant to manage the health risk of people that are enrolled on this program. Secondly, which is equally very fundamental, is the fact that majority of our people, especially healthcare facilities and the HMOs now, never believe or understand deeply the fact that there has to be an agreement on the rate of services you are going to be charging and what you are paying for. I tell people, I say, if you walk into any restaurant, they are not bothered about what is in your pocket, but they are showing you the menu list and the amount you are going to say their plate of rice. Should you want to bring in 10 or more people to buy that rice, you could stand a chance of negotiating some things in that plate of rice. But if it is just you and your friend that are buying, you can't start negotiating what is not. Most of the time, there is no basis for all of that to be done. Let me quickly give you the solution as we speak now.
Okay.
NHIA, as we speak today, has developed a contract agreement to be signed by the NHIA and the health maintenance organizations. As a matter of fact, we are including code of conduct into it. Because if there's anything we've usually seen playing out over the years, is the fact that the practice has never been regulated. And that led to a lot of sharp practices on both ends. Hospitals or facilities seem not to understand the fact that enrollees that are being referred to them by the HMO are meant to be managed looking at their internal tariff. Some of them, even gullibly, I'll say gullibly at this point, request for capitation. And some of us said, no. Capitation is a function of volume. Because from the public sector scheme, you need to have minimum of 2,500 enrollees as a primary provider for you to be able to manage that risk at that level.
Okay, so what's the good news for employees now?
The good news about this program is that, first of all, before now, the private scheme, I would say private scheme, has never been regulated by the authority. But with the passage of this law in 2022, May 19th to be precise, now that has given power.
Yeah, but despite the passage of that law, we've not seen.
What is it? The issue is this. The issue is this. There could be some challenges in the unpacking and implementing this particular law.
I mean, I can
say,
just a minute there, Otumba, that as a third-party employer, we always have to go back and sit down with clients to understand and share with them, what the law says. But the truth of the matter is that many HR practitioners out there who are leading and in charge of putting the employee welfare packages together are not fully abreast of this. And if they are not, they can put it forward to the CEO. And if the CEO doesn't know, then the employees do not get what the law actually has provided for them. So what is the way forward?
The way forward, first of all, is to create top-of-mind awareness for those that are seen to be critical stakeholders in driving the health insurance program. And if you look at any organization, there are two key technical buyers in every organization. We have the managing director, we have the HR person. So what we are planning to do and what we are doing in Ultimate is to systematically interface with those that need to be educated about what ought to be done. I tell you this afternoon, we've had cases where we had to quietly walk away from a particular account because of the perception and the line of discussion of those that are seen to be taking informed decision on the program. Everyone was just looking at the Naira and Kobo, and it's not Naira and Kobo we're talking about here. First of all, we should be concerned about the well-being of those that we're bringing on the service, on the program. Because what drives success for organizations globally, either you are into product or service business, is customer satisfaction.
Absolutely.
If you pay adequate attention to that, I have said it on several fora, you will become rich unconsciously because people give you things to manage because of the fact that your attention is on satisfaction.
Yeah, well,
now, let me come back to
now.
Let me come back to what you said concerning how best the people can enjoy this service.
Okay.
I have said it before. Let me go back quickly and reiterate this. The health insurance program we're talking about this afternoon is volume driven. At the provider's level is volume driven. For any facility to say, okay, yes, I love to be on this health insurance program, if you check their portfolio, they must have well over 2,500, 3,500. Because the same way we are looking at volume for health insurance is the same way IBOM is looking at volume for passengers.
Okay, but let's look at it this way. Every employee out there is 100% of himself. So volume that we are talking about is aggregate. As an individual, as a staff, it doesn't really matter if there are 2,000 people in a hospital, I'm sick, I need treatment. And that's what matters to me.
Let me address that. And the way forward on that is so simple and straightforward. I have mentioned it passively. Let me hit it on the nail on the head now. If you have 10 staff to be enrolled on this program, what that means is that, first of all, the HMO is expected to enter into contract agreement with the facilities they are going to choose. What exactly is it? Are we saying about what we're about here? Okay, I'm bringing 1, 2 staff from this organization. What? How much would you charge for this service? How much would you charge? Let me also say this at this meeting, at this program. Every facility that is accredited by the regulatory agency, even at the state level, they are expected to have their treatment tariff developed and reviewed by the states and endorsed by the states. Even if they are going to review it, they need to also review and represent for approval. Do you get what I'm saying?
Okay.
So it is this tariff that's supposed to be serve as the service provision platform between the HMO or HMOs and the facilities. And that is what should dictate what they are be charging. And that also play a major role in determining how many enrollees are we sending here. But what I'm saying, let me get it straight. We are not talking about capitation for private scheme. Let me just say that clearly.
I mean, many people out there would not know what capitation means.
Capitation is a certain percentage of the premium paid per annum broken down into per month and being paid in advance to the facility to provide defined primary level of care for the few that will show up within the 30 days that makes a month, and that is capitation. In the federal government program is 65% of the premium that is paid in a month.
So can we say that maybe the scheme is working for federal government staff, but for private employers it's not yet working? Can we safely say that?
We can safely say that. And why it's not working, I have explained it. Let me repeat. Is because majority seem not to understand the meaning of capitation. So facilities themselves, even we hear quite a lot of hospitals asking that we want capitation to be paid, and it's like, pardon me, capitation is a function of volume.
So are you saying it's just the claim that should be settled?
It's called fee for service. It's not the claim now.
Okay.
Let me explain it. If Dr. Femi Ogunlowo is going to his facility to assess care on the private health insurance program, first of all, ideally, the health maintenance organization should pre-book you, as in calling them. Dr. Femi is coming tomorrow, Saturday, to see the doctor.
Yeah, but
I'm just coming.
Illnesses don't
you see,
where
we are going. I'm just telling you. You see, when we're chatting in your office, I said whatever you want us to discuss here is on my fingertips.
Yes.
Okay. Now, that is the standard way of doing it. Okay? They put a call across. You're working. They're expecting you. Are you getting me?
Okay.
Because those are the bouquets. This pre-booking I'm talking about is part of the benefit package for all health insurance program abroad. Quote me anywhere.
Yes.
Check Kisa Permanente, check United Health, check any of the HMOs abroad. Pre-booking is.
So could it be that one of the reasons why employees actually don't enjoy the benefit of the HMO scheme is that we have not put in place the processes that can make that happen?
Some of us are doing that, but majorly I think it's equally important for us to highlight at this point the fact that the employers of labor are also not helping issues. And why they're not helping issues is because they see the premium as something that can be toyed with. And you will agree with me that should you choose to fly from Lagos to Abuja tomorrow, you can't walk into a bomb and say, how much is your ticket? 100. Can we pay 85? Are you getting me?
Okay.
So they are not things that are meant to be negotiated. That does not mean to say that.
Yeah, but it's volume business. So
I'm coming now. That does not mean to say that should you have volume, you can't use volume to negotiate. I know that. We all know that. Even if you want to fly 50, 60 staff for a program in Abuja, yes, IBOM will still give you serial discounts. That we all know very well. But not that because you have 10 staff and you are looking at 135,000 and say, can we make it 100,000 naira figure? And it's like...
Yeah, I mean, I know that we can continue with this for the next hours because a lot of people have issues when it comes to the benefit they get from their employers, relating to healthcare. But as we begin to bring this home, it appears to me that the starting point is actually getting employers to understand that it is not a privilege, it is not part of their core values. It is actually the right of the employee to receive healthcare. But I would like us to make a distinction. Is that healthcare benefit, is it limitless?
There can't be any health benefit across the globe that will be limitless. There certainly be a bundle. What that means is, if you buy a product, there could be a ceiling.
No, but what does we're talking about the law requires you to do. So what exactly is it that the law prescribes? I can cover you for malaria, I can cover you for primary health care. Because when people go into the hospital, they say, oh, this is major surgery. It is not covered under the scheme.
Let me explain something to you that I have seen over the years. Most of us don't read.
Okay.
Starting from the enrollee and even the doctor.
Okay.
Yes, I say this anywhere. I've interfaced with quite a lot of physicians, and you hear them talk about, yes, we have the operational guideline in our system. We even have the tariff. And I ask them, when last did you look at it to provide service? Do you get what I'm saying?
Okay.
So, and that's why there's another age. It sounds so funny, but these days you see Nigerians saying, or people saying that if you want to hide anything from Nigerians, put it in a book.
Mm-hmm.
Most of us don't read. And what we do, what we encourage now is that the benefit package should be circularized. Should also, as a matter of fact, be in the phone of everyone, so that by the time you are going to assess care, you first of all know what you are entitled to. Because if you and I should give our staff ticket that is valued at 5,000 to walk into any restaurant to eat anything, to eat what will value 5,000. By the time they walk in, they first of all begin to ask, how much is a plate of rice? How much is a piece of meat? Are you getting me? That goes to say something, because they know the value of the ticket they are holding, and they want to be sure whatever is going to be served covers that particular. So the same approach should be deployed by the enrollees that have been enrolled on this program. They should learn to ask questions by also even touching base with their HMO. What are my benefit packages? Are you getting me? And once that is exposed to you, you just don't look at it, and you also keep it on your phone. So, and when you get to your choosing facility and they are denying you
know your rights, you say this is within.
And they are also telling you that you are not entitled to this. After all, we also watch this Who Want to Be a Millionaire. Where at a certain point, when you are on the hot seat and there's a need for you to answer a particular question which you don't have answers to, they give you the opportunity to call someone.
Absolutely.
You call your HM for clarification.
All right, I think we have to bring it home. I think instructive thing for me here is, since we are saying we should read, I would like to invite every HR practitioner out there to actually familiarize themselves with the provisions of the National Health Insurance Authority Act of 2022, which is the starting point. As HR practitioners, as business owners, as CEOs, we should know what the law requires of us to do. It's not the goodness of our hearts to provide for health care for our staff. It is a requirement of the law. Yeah. I'd like to thank you so much, Otumba. And Praise, you're still there?
Yes, I am.
Great.
One thing I'm taking away is health is a right for everyone, not a privilege.
Thank you so much.
And let me share this before we shut down this program. What we're planning to do, like I did mention to you when we were in your office, is we're working now strictly looking at how to create top-of-mind awareness for Nigerians. Because that is very fundamental to even the enhancement of enrollment of this program. Because it's when people have information that they can begin to see the benefits. And we are looking at starting with even the HR or the organizations that are part of NECA. Because I'm on the governing council of NECA, and I keep asking myself, what role exactly am I playing here if I don't have the opportunity of meeting with the HR team and begin to expose some of those things to them? And also possibly meet with the
I think we're gonna bring DG here at the next episode, so that we'll talk to him generally about how do we ensure, because NECA, I'm also on the governing council of NECA, as you know, and it is the responsibility of NECA as Employers Association to also advocate just the same way it advocates for the benefit of employers, with government, to also advocate that employers also fulfill the requirements of the law. So it's important. We'll bring DG Wale, here and have this conversation with him and see how NECA as Employers Association can also pass this message down to member companies that healthcare is a right of employees and not a privilege that is given by the companies. I want to thank you so much. Yes, I mean, it could be interesting to speak to the unions too. In fact, in 2 weeks' time, I'm having some, union people coming for a meeting with me. So it might be an interesting thing to also have that conversation with them. Yeah. Thank you so much, Otumba. It's a pleasure having you on Workplace Whispers today. Thank you.
It was mine too to be here.
Cheers.
And we continue to do this regularly.
Thank you. All right.
Yes.
Bye.